benzodiazepine. The objectives of my talk are describe the role of benzodiazepines in psychiatric armamentarium, explain usefulness of benzodiazepines in consultation lines on psychiatry, and identify and address some of the controversies surrounding benzodiazepines. How did we get here? In 1950s, there was a drug called meprobamate. Some of the people may still remember it. It was discovered by Frank Berger, who's actually an interesting man who escaped from Central Europe during the war and was in England. And then he was working at Carter Wallace, which was a small pharmaceutical company. And he called this invention the meprobamate Milltown because it was a small town next to Carter Wallace factory or whatever. And he discovered actually he was not looking for anything like that. He was looking for a substance which was supposed to stabilize the molecule of penicillin. And when he was looking through different substances and giving it to rats, he realized that one of them was a little bit sedating. He wanted to call it sedative, but he was convinced by others that it provides tranquil feelings, and thus they invented the term tranquilizers, later minor tranquilizers from benzodiazepine. It was a blockbuster drug in 1950s. It was bigger than Prozac, and Prozac came out in 1990s, but it's almost forgotten. For instance, there was a drink called Miltini. It was from Milltown and Martini. It was the drink which instead in Martini, instead of the olive, there was a pill of meprobamate. That's what people were drinking at the time. And actually, the introduction of meprobamate was a very important moment because this is from a book by Andrea Tone, The Age of Anxiety. It is the very first time that millions of Americans and also the doctors too felt it was okay to take a drug for everyday ills, like anxious, depressed, or whatever. So surprisingly, the drug was approved without much marketing push. Actually, Berger was against marketing. He didn't like drug reps or whatever. So interestingly, the drug, which some people claim was not really effective, appeared in the water, in the drinking water of some American cities, even in 2008, of course, Las Vegas and Los Angeles, where else? So at the time that when the pharmaceutical companies were seeing this drug and the popularity, they wanted to have something like that too. They wanted to have something similar. So the Roche Pharmaceuticals asked their genial chemist, was a great guy, Leo Sternberg, also from Central and Eastern Europe, to develop Me Too version of a meprobamate. But Sternberg felt it was a boring thing to have Me Too drug, and he was going through many substances and many things, and this was actually some dye or whatever he discovered, and he looked into it, and he discovered in 1955 the first benzodiazepine, chlordiazepoxide. It became widely available in 1960. And he discovered a number of benzodiazepines. Then he discovered, diazepam, flurazepam, nitrazepam, but chlordiazepoxide was the first one which he discovered. And and they, benzodiazepines started to be used across the country, across the world. In 1977, they were the most prescribed drugs, medications all over. And they became popular not just because they relieved the anxiety, but because also for the usefulness in other indications, in insomnia, agitation, seizures, alcohol withdrawal, spasms, and so on. And they were evaluated from 1960 to 1990 for the efficacy in various anxiety disorders and other disorders, and I'm going to be talking about that a lot, and some problems, how they were evaluated in comparison to antidepressants. Psychiatrists, when these were the most prescribed drugs, psychiatrists were actually apprehensive about prescribing them. All right. And then the new antidepressants came in 1990s, the SSRIs, and pharma companies started to compete first among themselves for the approval of the SSRIs in different anxiety and related disorders. They were competing among themselves, and the competition sometimes impacted actually the approval. The example is fluvoxamine. Fluvoxamine was the fourth, was a third of or fourth SSRI coming to the market. The company felt it's too much of competition, depression area, so they get it approved for obsessive compulsive disorder. It's just a regular SSRI, so it could be used for all the other indications, but they got into the market through the OCD indication. Due to historical consequences, the issue of regulatory agencies approving benzodiazepines was disadvantageous for them, because most of the benzodiazepines were approved for use prior to the arrival of DSM-3. In DSM-2, before the DSM-3, there were only 3 anxiety disorders: anxiety neurosis, phobic neurosis, and obsessive compulsive neurosis. Then the DSM-3 arrived, and we started to have the other diagnoses, such as panic disorder, generalized anxiety disorder, and so. And after these diagnoses were introduced, SSRIs arrived, so they were getting approved in these indications, which we have now. But benzodiazepines were out of patent, except for alprazolam, so you were not able to, there was no interest to get them approved for panic disorder because there was no drug company which was interested in that. And so that's what happened. So the pharmaceutical industry this way offered psychiatry an alternative for treating anxiety and anxiety disorders, supposedly better than the benzodiazepines. They brought the SSRIs, they got approved with certain indications which on the paper benzos were not approved for, and their use spread across very quickly. What are benzodiazepine properties? They're anxiolytic, they work for seizures, they're hypnotic, sedating. They also relax the muscles, including probably the smooth muscles. What is the role in the psychiatric armamentarium? So they are used for GAD, they are approved for generalized anxiety disorder, for panic disorder, namely alprazolam, I'll be talking about it, and clonazepam. For insomnia, seizure disorders, clonazepam is approved for muscle relaxation. Anxiety associated with medical illness and anesthesia, alcohol withdrawal. So many uses. They are really one of the most used psychotropic medications. Interestingly, psychiatrists write only about 20% of the prescriptions in this country. Part of the reason, as I said, psychiatrists are apprehensive. Part of the reason is that most of the anxious patients are primarily seen in primary care offices and not seen by psychiatrists, and then primary care physicians prescribe benzodiazepines. And also they prescribe them for anxiety, somatic complaints, or true somatic disease, or whatever, but the anxiety is a problem. And then when they prescribe them for several months, they refer them to people, for instance, like me, because they don't want to prescribe it for a longer time. At least I know how to use benzodiazepines, I'm fine with it, but some of my colleagues are against it, so they would not take patients like that. Benzodiazepines are not considered first-line treatment for anxiety disorder, and it's not clear why not. And I'm going to talk about it. So here now we talk about the anxiety disorders. They're efficacious, and the original evidence came from the trials or assumption that if one benzodiazepine works for some indication, that means the other ones are probably working too. We do the same thing with other, with SSRIs and so. The strongest evidence actually came from efficacy trials of alprazolam in panic disorder. Because alprazolam came in 1990s, so DSM-3 was already there, so the diagnosis of panic disorder was there. And so there were a number of trials, and I remember I'm old. As I tell my residents, I'm 100 years old. I remember stuff when there was an issue of journal there then called Archives of General Psychiatry, which is now JAMA Psychiatry. There's a whole issue dedicated to trials of alprazolam at that time, surprisingly. Though the first trial of benzodiazepines in panic disorder was not with alprazolam, it was diazepam by Russell Noyes, comparing it to propranolol, panic attacks and phobic symptoms responding fine to benzodiazepam, not so to propranolol. Then came the trials which were examining alprazolam, those ones which I mentioned. Some of them were in that issue of the Archives of General Psychiatry. These are trials by Jim Ballinger and his group. They were, alprazolam was better than placebo at the first week. And the week 4, 83% of patients got better versus 43% on placebo, which is really a substantial difference, which you don't see in many placebo-controlled trials in medication these days. 50% of alprazolam were panic-free, 28% on placebo. And then they were compared in panic disorder with other medications. Alprazolam was better than in trial by Munjak. Propranolol was same as lorazepam in 2 trials by Dennis Charney, and so the dose of lorazepam was higher. The issue at that time was like, okay, some benzodiazepines may not be working. It turns out it's the matter of dose. Alprazolam is more potent, so the dose of lorazepam had to be twice as much in a trial than alprazolam in the numbers, like 7 milligrams of lorazepam versus 3 milligrams of alprazolam. George Tessar published a study of alprazolam and clonazepam that were better than placebo. And then they were compared to other medications, I would say, in panic disorder. For instance, to imipramine. It was a large study. You have to remember that before the arrival of SSRIs, we used to treat panic disorder with imipramine. We started with a low dose and climb up and everything. So they compared alprazolam with imipramine, and they were very similar by the effect, though alprazolam started to work quicker. Both were better than placebo. Alprazolam was better tolerated. Another study comparing with imipramine found it was 6 months maintenance study by Schweitzer, and Carol Rickles was in that, I think. So they found out they both groups were panic-free, but imipramine was less tolerated than alprazolam. Doses were fairly, okay, almost 6 milligrams of alprazolam, 175 milligrams of imipramine. My residents would not dare to prescribe that number of, amount of imipramine. People are scared of tricyclics. Actually, there were not enough studies, and there's still not enough, which would compare benzodiazepines to SSRIs. There's a series of reports by Antonio Nardi and Rafael Freire from Brazil, where they compared clonazepam and paroxetine in panic. They had originally the 8-week open label study, 2 milligrams of clonazepam, 40 milligrams of paroxetine. Clonazepam was a little bit better on several measures of panic and anxiety. Then they did a 3-year follow-up. And in the 3-year follow-up, clonazepam was better on CGI. And they discontinued the treatment in people who got into remission, but then they did a follow-up in 1, 2, 3, 4, 5, 6 years later. And there was lower relapse rate with clonazepam in year 1 and 6, and the relapse rates became very high anyway, because in year 1 it was 50%, and year 6 was 89%. Then generalized anxiety disorder, the role of benzodiazepines in treatment of that. Benzodiazepines were actually used in treatment of generalized anxiety disorder under a different name, under the anxiety neurosis, which was the predominant symptomatology, even before the DSM-3 or whatever. There are studies showing the efficacy of alprazolam up to 3 milligrams in generalized anxiety and panic, and the efficacy was similar in diazepam in a little bit higher dose and everything. This is from Canada. And benzos were comparing to other benzodiazepines in the generalized anxiety disorder. Lorazepam were equal to romazepam, then alprazolam was equal to etizolam, and there was adenosine. Those are medications which are not available in the United States, most of them, except of lorazepam, and so, but they were tried around the world, and again, confirming that benzodiazepines are effective in this indication. Then they were compared to non-benzodiazepines in treatment of generalized anxiety. The first study was actually comparing it to buspirone, 2 milligrams of alprazolam to 18.7 milligrams of buspirone, the mean dose. And buspirone failed to many patients failed due to side effects or lack of efficacy. I have a problem with this study because when I use buspirone, you have to use much higher dose. You cannot use like 15 or whatever. Then it's like an expensive placebo. But if you get over 30 up to 60 milligrams, it does work. There were studies which found out diazepam equal to buspirone, and then again, bromazepam, which is not available here, equal to chlorprotixine, which is an antipsychotic, and diazepam equal to abercrombie Rickles study. So then they were also compared to imipramine, to trazodone, and there was a study by Carol Rickles, diazepam compared to imipramine and trazodone, and they were found equally efficacious. One study compared it to venlafaxine, one study to lorazepam. They were equal in the indication for generalized anxiety disorder. Then people started to say, okay, so what can we conclude from the literature? In 2018, there was a study, there was a meta-analysis by Gomez and colleagues, which put together 56 studies. And they concluded in the conclusion that the most common forms of pharmacotherapy for adult GAD are moderately effective, with benzodiazepines being the most effective drugs. So Carl Rickles' Reinhold wrote in 2015 actually also that the evaluation of literature suggests consistent, reliable efficacy of benzodiazepines in improving the central features of generalized anxiety, both the psychiatric and somatic. Benzodiazepines elicit an earlier response than the antidepressants, and provided that the response occurs by the 8th week, it tends to be sustained throughout the length of treatment. By the way, Carl Rickles is still alive. He celebrated his 100th birthday. He's a centenarian. And interesting, he practiced medicine, psychiatry on the same floor as Aaron Beck. Must have been very interested. Then some people look into meta-analysis and systematic review. In 2016, there was an Italian group led by Offidani. They showed that treatment with benzodiazepines resulted in comparable or greater improvement and fewer adverse events in patients suffering from GAD, and that benzodiazepines are more effective in reducing panic attacks than tricyclics in the meta-analysis. Similarly, there was another meta-analysis looking at the side effects, and the meta-analysis showed the SSRIs have less favorable side effect profile in acute than benzodiazepine, the acute treatment of panic disorder. So this is the summaries of the literature on panic. And so then there are other anxiety disorders, and benzodiazepines work in social anxiety. Original studies are done, small studies by Bruce Lydiard in Dr. Spollen's former place in Charleston, South Carolina. And then there were more and more studies showing that clonazepam is basically better than placebo in double-blind fashion or whatever. The interesting point here, look at the difference in the last bullet between the active drug and placebo. You don't see differences between placebo and active drug like this in recent trials, which is amazing. It's probably because it was done in academic settings and not in some shops used by drug companies. Clonazepam was compared to CBT, was comparable to CBT, was in symptoms was a little bit better, was compared to, but it was actually added to paroxetine and compared to paroxetine alone, paroxetine and placebo, and was also a little bit better. So it's been found that really effective in social anxiety disorder, and that's really mostly used these days. There are some other weird indications which we may consider weird, but It was tried in agoraphobia, that's not it, but it was also, there was a double-blind placebo-controlled study of intranasal midazolam in claustrophobia in people who are put into MRI machine. And of course, midazolam was found to be more effective. So Carol Rickles wrote also in 2013, there is no evidence for the superiority of the new antidepressants over benzodiazepines, both in terms of efficacy or safety. It exists for either short-term or long-term treatment. Doesn't matter which treatment it is, there's no evidence for that. Benzodiazepine toxicity, adverse events, and withdrawal symptoms, not better efficacy, are usually cited in support of the use of antidepressants or benzodiazepine in anxiety disorders. Yet antidepressants are not better tolerated than benzodiazepines, and they also can cause withdrawal effect, which I'm going to mention a little bit later. So what are benzodiazepines in other disorders? They've been used in, in depression. IRLS showed that, alprazolam relieved secondary depression in some people. And then the Italians again put together a systematic review of 38 studies and found that benzodiazepines and tricyclics are comparably efficacious in anxious depression. Interestingly, in that study was only one, in that systematic review was only one study comparing benzos to an SSRI. So they concluded there is no indication that antidepressants are preferable treatment for anxious depression. It's an interesting notion here. If you look back into diagnostic criteria, until DSM-5, major depression symptomatology did not include anxiety. So whether students are learning CCAPs or whatever, there was nothing about anxiety. Only DSM-5 added an anxiety specifier for major depression. They are used in schizophrenia, catatonia. There are numerous studies about that, a lot, mainly about the use of lorazepam, because lorazepam gets better absorbed from IM sites. They're used in akathisia, in associated anxiety, in schizophrenia. People added them to neuroleptics. And of course, in psychotic agitation, the famous B52, 5 of haloperidol and 2 lorazepam. They're preferable in use for alcohol withdrawal. Chlordiazepam is actually approved in that indication. Benzodiazepam is also useful. There are 5 benzos approved for insomnia. Triazolam, temazepam, estazolam, flurazepam, clozapam. I'm not going to ask you for the generic names because nobody knows that the generic, not generic names, brand name, that the brand name of clozapam is Doral. Nobody has ever used clozapam. They're used in GI endoscopy, in colonoscopy. If you're as old as I am, that you had colonoscopy, you know that some of the guys will give you midazolam as an introduction. They're used by dentists, midazolam. When they did some work on on me, they gave me midazolam. I didn't feel anything, but they didn't want me to drive after that. Now, so I show that benzodiazepines are very useful in treatment of anxiety disorders, and I said I'm going to say and demonstrate that they're also useful in psychosomatic medicine. Anxiety could be a warning sign to help individuals to focus on the potential problem. Some mild or moderate anxiety could be normal and could be okay, as it doesn't interfere with functioning, interferes maybe minimally. But sometimes it's not, and so the differential diagnosis is very important to decide what anxiety it is and medically ill and what are we going to do. So a long time ago, Mark Shekett wrote an article that says what anxiety is it in medical ill? Is it primary anxiety disorder? Is it associated with drug abuse or prescription drugs? Is it discontinuation of medication? And then when it is related to medical illness, what is it? Is it reaction to catastrophic illness? Or is it an intrinsic factor or a physical disorder? Or is it in the context of some specific medical disease? So as far as the catastrophic anxiety related to catastrophic illness, if mood would develop, mood disorder as a reaction to catastrophic illness, then of course we probably would use antidepressants. But if you have periods of some escalating anxiety or continuing anxiety, then probably benzodiazepines may be preferable. Remember what I said about the anxious depression, that there's evidence that benzos are working better in what is called, what some people would call anxious depression. Some of the medical disorders are associated, so they have some intrinsic symptoms of anxiety, like mitral valve prolapse. When I was younger, we studied panic disorder. There was a lot of literature about association of panic disorder with mitral valve prolapse. There were studies done on that. So hyperthyroidism, people are anxious. Cardiovascular disease, I'm going to talk about it a little bit more, but anxiety has been found as a predictor of the risk of major cardiac events in that famous study by Fraser Smith published in 2008. Anxieties in respiratory disease, even though there I would not get into benzodiazepines because they suppress the breathing center. In other endocrine diseases, porphyria, pernicious anemia, and meta diseases. In chronic illness, that was more intrinsic, but then we talked about a chronic illness. Anxiety is present in cardiac disease, people with heart attack, surgery or whatever, a lot of anxiety. People with GI problems, especially three of them, I'm going to mention them again: peptic ulcer, irritable bowel syndrome, ulcerative colitis, and in some other single letters as well. Not necessarily every anxiety intrinsic to the medical illness should be treated with benzodiazepines. Like as I mentioned, respiratory disease, I would not treat people with benzodiazepines because COPD and so on. But the benzodiazepines have been found to be useful in treating anxiety disorder associated with most of mentioned medical disorders. The treatment of the anxiety in medical illness should be guided by diagnosis, underlying medical condition, medications which are used already for the illness, some side effects of medications used for anxiety, the intensity of anxiety, maybe presence of sleep because problems because it could help. So there are several situations which may favor use of short-term use of benzodiazepines in medical illness. Stress related to hospitalization. I would say, especially nowadays, when you go to the hospital, you have to be very healthy. I have a lot of strength and support to survive hospitalization. I had some problems and I had a broken arm and I had a surgery. It was anxiety provoking what was going on. Medical procedures, and then anxiety aroused by the medical condition. Some people, I worked with some people who work in the Cancer Institute, and a lot of cancer patients, when they come, they have high anxiety and problems. But nevertheless, also numerous conditions and diseases could and do benefit from a longer use, not just from the acute use of benzodiazepines. This is again mentioning of the Fraser Smith study from 2008, that anxiety and depression predicted greater major adverse cardiac events in patients with stable coronary disease. Then there was a study by Goodwin who found out that cardiovascular disease was associated with increased likelihood of any anxiety disorder. So he felt that every person with cardiovascular disease should be evaluated for anxiety, and that should be addressed. There were some other studies, like in Canada, where the prevalence of panic disorder and agoraphobia, or GAD, was higher in people with cardiovascular disease. That led the Italian authors again. That's the study around Giovanni Fava. When they questioned if depression is really the wrong treatment target for improving outcome in coronary artery disease, they questioned it. Lasagna in 1977, he was a big guy in the FDA, and so wrote that reasons to believe that benzodiazepines not only possess the anxiolytic effects universally attributed to them, but may also ameliorate somatic complaints affecting such systems as the cardiovascular and gastrointestinal, in addition to conditions such as tension, headaches, and back pain. So he said in 1977 that it should be done. Dick Shader, another old man who's still alive, in 78 observed that physicians commonly prescribe benzodiazepines as part of a long-term management of certain medical conditions, so to be adversely affected by anxiety-related autonomic system hyperactivity. I will return to some Dick Shader's quotes. So in our cardiovascular disease, benzodiazepine use. One old study used 85 milligrams. I would probably not use 85 milligrams of benzodiazepine in somebody who was cardiac disease, but after myocardial infarction, but they found it useful. Then there are some studies showing that in patients with stable angina pectoris, people who received alprazolam with propranolol were doing better than people with receiving just propranolol with placebo. And similarly, there was a significant reduction of silent myocardial ischemia in patients who got alprazolam in addition to propranolol and nitroglycerin patches. This is about some use in hypertension. Some people outside of the United States use additional benzodiazepines to people with hypertension that they found it, but those are all benzos which are not available. So you can only assume that benzos which are available in the United States may be also helpful to give to people with hypertension. This was an interesting study which was published about 6 years ago in Psychotherapy and Psychosomatics, which showed there's a retrospective review of charts of people with chronic heart failure. They found out that people who were prescribed benzodiazepine at a certain time during the heart failure, there were different benzodiazepines, that they had 15% reduction in the risk of mortality. It's not a big number, but it's at least interesting. I don't know what the mechanisms could be, whether it's to decrease anxiety, stress relief, help in insomnia, decrease the allostatic load, or whatever. In the GI illness, I wrote an editorial about it. There are 3 GI problems which have may be exacerbated by anxiety, colitis, ulcer, and irritable bowel syndrome. Anxiety has been found out in different studies to be common in people with functional bowel disease. And people who have unexplained GI symptoms reported higher lifetime episodes of major depression, panic, and agoraphobia, or people who had 2 unexplained GI symptoms had higher lifetime prevalence of depression, panic, and agoraphobia. And so there are studies on that. There's also some evidence from animal and human studies that benzodiazepines may relax smooth muscles in duodenum, for instance. All right. So long-acting benzodiazepines could be especially useful considering the changing tone of the smooth muscles in GI system and so on. So they were used, benzodiazepines were used in some GI problems. Mirtazapam was used for functional bowel disease a long time ago. Then diazepam, lorazepam they're significantly better than placebo in relieving functional GI distress. Same with lorazepam comparable to diazepam in relieving these problems. So they were used in GI problems, and they were found useful. And wait a moment, I was going to say something. Yeah, I'm going to probably say that a little bit later. They were also used in other indications in psychosomatic medicine, seizure disorders, status epilepticus, headache, burning mouth syndrome. Interestingly, I didn't know there's a topical clonazepam. And also, interestingly, the interesting example was the use of vaginal diazepam suppositories. Diazepam is available in suppositories to treat pelvic fibromyalgia and pelvic pain. So they can have some side effects, no question, in medical care. So the sedation could be a major thing. So you may try to use some different diazepams than the usual ones I've been talking about, for instance, for hepatic disease because of the metabolism, so it's not a buildup in the system. You should not be using them in sleep apnea or chronic obstructive pulmonary disease. Interestingly, in my mind, they have a favorable side effects on GI system problems because antidepressants either constipate you, the tricyclics, or cause diarrhea, SSRIs. Benzodiazepines do not cause any of this. All right, so in conclusion about psychosomatic medicine and use of benzodiazepines, the results of clinical studies, though some of them are small, are encouraging. So benzodiazepines should be used in treatment of anxiety in patients with different medical illnesses. And they seem to be very helpful in different indications. Now, there are some controversies. I probably am not going to cover all of them, but I try to cover the major ones. Major controversies are around sedation, lethargy, withdrawal, discontinuation syndrome, abuse potential, dependence, psychomotor impairment, cognitive impairment, and teratogenicity. I'm not going to talk about teratogenicity. It's clear, it's there. You should avoid them in pregnancy and so. FDA commissioner fairly recently issued a statement that while benzodiazepines are important therapies for many Americans, they are also commonly abused and misused, often together with opioid pain relievers and other medicines, alcohol, and illicit drugs. They're taking measures and requiring new labeling information to help healthcare professionals and patients better understand that while benzodiazepines may have treatment benefits, they also carry with them an increased risk of abuse, misuse, addiction, and dependence. So I'm going to talk about it. First, I want to mention the withdrawal and discontinuation. This is, again, I think, part of secret of whatever marketing strategy of antidepressants makers. Because is it a semantic thing, so bias or whatever? Withdrawal and discontinuation is the same thing, but we say, withdrawal has a bad connotation, so we say benzos have withdrawal symptoms, while antidepressants have discontinuation syndrome. They're the same, and give me a break. If you try to sometimes discontinue venlafaxine, you will know what I'm talking about, discontinuation syndrome or withdrawal from some antidepressants. Other drugs and antidepressants have unpleasant symptomatology on discontinuations, for instance, steroids or whatever. There's a great review by Fiametta Koshi and Guy Schunard, acute and persistent withdrawal syndromes following discontinuation of psychotropic medication in psychotherapy and psychosomatic. Good article. Common symptoms of withdrawal, I don't think I don't need to already review them in detail for clinicians: anxiety, jitteriness, palpitation, hypersensitivity to light. People always think that they're going to have seizures and then they discontinue benzodiazepines. That is actually fairly rare and happens not right away. It depends on the half-life. With diazepam, it could happen in 5 to 7 days. I remember I had a patient who came to me and says, I'm not taking any of the crap you're prescribing. I stopped it. She was on clonazepam. I said, I want to stop it. I said, well, okay, well, let's talk about it. She says, there's nothing to talk about. I already did yesterday. And I looked at her and I said, okay, I'll see you in a week. And she said, why? I said, you'll see. You will be back in a week. And she came back because she started to have withdrawal symptoms. And then she was willing to talk about how to do it. So with shorter acting drugs, you can have withdrawal in 2-3 days. But when you consider the withdrawal, you need to think about the issues of rebound anxiety, psychological belief that medication is necessary, overreaction to somatic symptoms. It's not just simple withdrawal. Interestingly, the withdrawal does not occur in all people who stop benzos suddenly. Some factors make the withdrawal stronger or better or worse. Some of them are related to drugs itself. Some of them are on patient level. Higher doses of benzodiazepines, shorter half-lives, longer duration of prior therapy, and more rapid taper make the withdrawal worse. On a patient level, people with panic disorder are more sensitive to withdrawal. People who had high levels of pre-taper anxiety or depression, people with personality disorders, and people who are using alcohol or drugs. How to do just I mentioned it briefly. You have to take care of it. It takes some time. That's the problem. People don't want to spend time with patients because you have to work on the reduction of the dose, and the max I would reduce in a week would be 25% of the dose. First half of tapering could be quicker. Later phase has to be slower. And I warn you, the adjunctive medications which are touted as helping in withdrawal, like carbamazepine, valproate, buspirone, they don't work. Not even gabapentin. The only thing which probably help would be a benzodiazepine, which has a longer half-life. There's also some notions in some review articles that CBT may help, but I don't think it does. Now, the abuse potential. There's an ongoing controversy about the use of benzodiazepines and there's abuse potential. There's a clash between people who say absolutely not and the people who say, oh, why not? You know, this orthodoxy, maybe we can try it or whatever. Where is it coming from? What is the problem? The addiction specialists who see patients who are addicted to medications and substances of abuse and everything, they perceive benzodiazepines as addictive, as they see many addicts who also use benzos. Clinicians who work primarily with non-addicted patients, like for instance me, they see a good side of benzodiazepine. That was written by Balon studies from Australia. Now, the DSM-5, and I mentioned this on a few slides briefly, what DSM-5 says about there's a lumped together sedative, hypnotic, and anxiolytic drugs use disorder. And I have DSM-5, it's in DSM-5-DR2. It has to be problematic pattern of these drugs leading to clinically significant impairment or distress as manifested by at least two of the following occurring within 12 months period. And that means that you have to use them in larger dose. There are unsuccessful efforts to cut down or control use. There's a great deal spent in activities necessary to obtain these drugs. Well, I don't know about anybody who spends a lot of time trying to get benzos. There has to be a craving to use these drugs. There has to be repeated use resulting in failure to fulfill major oral obligations, absences from work or whatever. There has to be continued use in spite of having a persistent or recurrent social interpersonal problems caused by these drugs. And there has to be impairment of occupational, social, or recreational activity. So all these things, two of them have to be there. There has to be also use of these drugs in situations which are hazardous, physically hazardous, like driving when impaired, continued use of them when there's psychological problems, and then tolerance. People talk that tolerance has to be present. Tolerance is marked the need for markedly increased amount of the sedative, hypnotic, or anxiolytic medications to achieve intoxication or desired effect, and a markedly diminished effect is continued use of the same amount of this drug. But there is a note in DSM-5 and 5-DR that this criterion is not considered to be met for individuals who are taking these drugs under medical supervision, which people don't pay attention to. Similarly, when you talk about withdrawal as manifested by the withdrawal syndrome and the need to take these drugs to relieve the symptoms or whatever, again, the DSM says this criterion is not considered to be met for individuals taking these drugs under medical supervision. And the prevalence of this disorder, the use disorder, is fairly low. It's one of the lower, and it's lower even in older individuals. It's 0.3 to 0.5%. So in the text if you put some text from DSM, it says that clinically appropriate use of sedative and hypnotic anxiolytic medications, individuals may continue to take benzodiazepine medications according to a physician's directions for legitimate medical indication over extended periods of time. even the physiological signs of tolerance or withdrawal are manifested, many of these individuals do not develop symptoms that meet criteria for the anxiolytic use disorder because they are not preoccupied with obtaining the substances, and its use does not interfere with their performance or usual social or occupational roles. I'm not saying that these things don't happen, don't exist, but I'm saying that it needs to be properly diagnosed and put in clinical context. Here is a very important, I said before that I'm going to mention Dick Shader again, note from Dick Shader. He said, since benzodiazepines cure neither anxiety nor insomnia, symptoms recurrence can be anticipated after discontinuation of the drug. So we also always in psychiatry have to see the difference between cure and treatment. We don't cure many diseases in psychiatry, we treat them. All right. They've been taken occasionally for recreational purposes, no question about it, in high doses. But the research on primates, this is from the APA Task Force on Benzodiazepines published in 1990. I admit that I stole it from the library of the Lafayette Clinic, and the clinic was closed, so I have it at home, the book. It says that the reinforcing effects of benzodiazepines are consistently weaker than those of drugs of abuse, such as sedative, hypnotic, stimulants, opiates, but stronger than those of drugs with little abuse potentials, as chlorpromazine. Benzos are not taken frequently alone for recreational purposes. They are mostly taken in high doses for recreational purposes with pattern of multiple drug abuse. They're mostly taken by those with a history of taking other drugs, and occasionally they may be taken for euphoria and effect. They may have sometimes. They've been unfortunately taken by opiate abusers. That's a problem. On people on methadone, cocaine abusers take them to ease the crash. Alcohol abusers also take benzos, and so there are individual differences between possible abuse of benzodiazepines like alprazolam, diazepam, and lorazepam are more reinforcing than some other benzodiazepines, and alprazolam has had more positive effects in alcoholics in an old study. All right. The frequently cited issue of tolerance. Tolerance develops mostly to the sedative or psychomotor effects, but not so much to anxiolytic effects. That's maybe slight increase, but usually it doesn't happen. So, and the issue of psychophysiological dependence or psychiatric drugs, if taken for more than a brief period, may produce discontinuation signs and symptoms. All right. Physical dependence at a therapeutic dose, according to the task force, is not a major problem. Ed Silberman wrote a long time ago that most long-term benzodiazepines users tend to decrease the dosage over time. Patients frequently do not take less benzodiazepines than prescribed. I had this experience with them. About half of the people who are withdrawn successfully from benzos relapse. And so chronic use of benzodiazepines may be appropriate and beneficial for people with anxiety disorders. The task force will talk more about, and I want to jump over this slide because they were basically saying the same thing which I already said before. So I jump over this. I mentioned the safety of benzos in overdose. You can take 30 times the normal daily dose and you'll be okay. You may be sedated, drowsy, have some ataxia, slurred speech. It may result in respiratory depression. That's why in the management, you have to have assisted ventilation and gastric lavage and so on. They have additive effects of CNS depression with ethanol, barbiturates, opioids, and so some drugs may increase their levels, like ketoconazole, fluconazole, nefazodone, through the 3A4 system. And some drugs that decrease triazole benzodiazepines include carbamazepine. So do not combine benzos with opioids. There's an increased risk of fatal overdose. There's a black box warning which comes from the North Carolina study. There may be some exception to this rule that you may combine in patients with severe pain, you may combine benzos and opioids, but it requires a very close collaboration with pain specialists. And I've done it because I work in a pain fellowship here. And interestingly, I had some patients, I gave them the choice. You cannot take these two drugs together. Decide, opioid or benzo. They decided for benzodiazepine, interestingly. About the other controversial issue is the risk of falls in the elderly. That's probably true, but that happens with other drugs. Then there was the issue of benzodiazepines and Alzheimer's disease. There was an association study from Canada that had some problems in the interpretation. An association doesn't mean causality. Actually, there's a better study. It was a rigorous nested case control study from Denmark, which is published in American Journal 4 years ago, which did not reveal any association between use of benzodiazepines and Z drugs and subsequent dementia, even when exposures are accumulated or divided into long and short-term acting drugs. There were actually some results which were compatible with protective effects, which is interesting. And those are really good study, you know, in Scandinavia, you can do great studies like that. But there is a risk of some cognitive impairment associated with injury accidents, mostly in the elderly. So at the end, before we get to questions, I have few words of wisdom from the wise man. Dick Shader and David Greenblatt wrote a long time ago that in the era of personalized medicine, the ultimate decision to prescribe a benzodiazepine derivate or any other medication should be based on the assessment of the patient's degree of emotional distress and level of functional disability, the potential hazards of non-treatment in relation to the probable success of pharmacological treatment and the hazards of the medication. They continued that the duration of benzodiazepine treatment should be tailored to the character of the underlying illness. Patients with intermittent symptoms or symptoms that are triggered by identifiable anxiety-provoking situations are candidates for intermittent therapy. Those with persistent unremitting symptoms may require more continuous treatment, but the appropriate duration of the therapy has not been clearly established, like with any other psychotropic medication. More recently, there were a couple interesting comments, brief articles by Jerry Rosenbaum. Jerry Rosenbaum was the head of psychiatry in Mass General Hospital and has done a lot of pharmaceutical trials. He wrote in American Journal of Psychiatry that the efficacy of benzodiazepines in anxiety is well established, but based on the current practice of many more recently trained physicians, these medications reduce anxiety for the physicians themselves by their refusing to prescribe them. So doctors get relief of anxiety by not prescribing benzodiazepines. Made this comment. And he continued that benzodiazepines are medications. As such, they are intended to be prescribed by those trained in how and when to use them and how to weigh the risk and benefits. They are also intended to be prescribed to address suffering, distress, and functional loss from psychiatric symptoms and disorders. As with many tools available to the clinicians, they are imperfect, but are potentially beneficial. Jerry actually wrote in that comment that his son was a resident in psychiatry and he was, indoctrinated against benzodiazepines. So Jerry wrote that he felt like he was on the other side of the Spanish Civil War and he was talking about benzodiazepines. And then in Focus in 2021, he wrote, if fear biology is analogous to the immune system to protect people from external threat, then acute and sustained anxiety is like an autoimmune disorder where the response is inappropriate, sustained, disabling, and associated with life-shortening consequences. The dysregulated protective response becomes the biological threat itself. And he said, in a sense, the benzodiazepine is the prednisone for this autoimmune responses to decrease in quote mark, inflammation and restore function. He compared it like this. These are drugs which influence many things, but help with important issues. So I think I'm almost at the end of my time, and I'm at the end of my talk, and I'll be open to some questions.
Excellent. Well, you've certainly increased my anxiety quite a bit today, Dr. Balon, because this is fascinating. We have one question in the chat, and I'll read that one. Because you're I think questioning, like you say, a lot of our recent training and maybe accepted wisdom, I guess, maybe of the more recent, those of us who've trained, I would say more recently. I've trained 25 years ago. So okay, so let me go to the question in the chat first, okay? And I know if people need to leave, that's fine. But if those of you who'd like to stay and ask questions, please do. So do benzos have the same iatrogenic effect? That's how the question is written, that some opiates have, specifically making patients more prone to anxiety over time, in the way that opioids can increase pain sensitivity? Kind of a sensitizing effect over time.
In visceral effects, you can see, let's say, increased sensitivity to lights and so, but otherwise, I don't think so. Actually, opioids have much more iatrogenic effects. Number one, the pain specialists would tell you that they don't work in long-term use. All our pain specialists will stop opioids after acute treatment. They say in long term they don't do the job. The other thing is, which many people are not fully aware of this, but some hospitals do not do scheduled elective surgeries on people who take opioids, because opioids dump the entire endocrine system. So the flight response and everything is much more less in people who take opioids. That doesn't happen with benzodiazepines. So okay. I don't think so.
Okay, you don't think so. Dr. Oliveto, did you have a question, comment?
Well, a couple of things. I'm a behavioral pharmacologist by training. So, in the non-human lab, giving a benzodiazepine to a squirrel monkey made them so tame. It was amazingly profound to see, because it alleviated that anxiety. And but I also recall, even back in the 70s and 80s, how much the drug companies, I think, shot themselves in the foot by putting out there about how much, like, I remember ads of like a college student, a female college student, looking sad with her books and saying, oh, your daughter is going off to college and she's going to be so anxious, so you need to get her like some diazepam or Librium or whatever. So how much do you think that this came about? Because it kind of proliferated our culture. I remember a Woody Allen film where he was on a street and the female lead was, getting really anxious and upset. And he's like, does anyone have a Valium? And all you saw were all these hands with pills, right? Willing to share the Valium. So how much of it is a backlash against it, just kind of the over aggressive marketing and really proliferating the market, and then having some difficulties in terms of overdoses, even though it has an incredible safety profile relative to many of our other tools in the shed. So any thoughts on that?
Well, I think that it is partially. When I was young, I remember, all these ads and everything. And so, and I also think there was this subtle indoctrination by the makers of SSRIs, which were always saying, we don't have these problems. But if you think about it, you talked about the college students. What first came to my mind is that, okay, college students don't take benzodiazepines, but most of them take what these days? They have to use something, so they use stimulants.
Or they're on SSRIs and they're told,
and marijuana.
Yeah.
Marijuana. I'm getting out book this next month about the other side of marijuana by Epipress. Marijuana is a disaster. People just don't realize that. But one of my colleagues came and said to me, well, my niece just got to medical school, not 2 hours. And she came to me and said, can you prescribe me a stimulant? Every medical student takes stimulants. So now they take stimulants. I don't know what's worse. But I agree. Some of the was shooting in the legs. That's where I think what Berger, whom I mentioned as the inventor of meprobamate or discoverer or whatever you want to call him, he didn't like the promotion of meprobamate being so strong by drug reps and everything. And I think yes, you're right. There has been backlash to it.
I want to, looks okay. So in the interest of, and trying to have pushing back a little bit, Richard. So, the studies you've cited, first of all, a lot of them are older, which is fine, but we don't have more recent data, and I'd like to see that for one thing. And also, we see a lot of patients, and those patients presumably were diagnosed thoroughly, I'm going to assume, okay, in clinical trials, with excellent, we hope, diagnostic protocols. We hope. Okay, we see. I'd love it if any of the residents or other attendees want to speak up too. But when I supervise in the resident clinic, we get a lot of patients who come to us already on multiple medications, SSRIs and benzos, and maybe they're also on a trazodone, maybe they're also on other classes of medications. And I don't, our residents do a great job, kind of reviewing diagnoses, et cetera. But I don't know, how do we know patients aren't, these are often being prescribed by primary care doctors, right? I always thought of it, and maybe I'm been deceived over time, I don't know, as the doctors handing out the benzos to relieve the doctor's anxiety. I've got this patient in front of me, and I need to do something for symptoms that maybe are not where a diagnosis has not been carefully assessed.
Well, there are multiple questions in what you said.
Yeah.
I will start from the back. I think that residents need to learn to prescribe benzos, need to learn to prescribe tricyclics and other things which I prescribe. And so there's an editorial in Journal of Clinical Psychopharmacology by Tony Rothschild about a lazy psychopharmacology. People don't want to do anything which is more complicated. Because, and I tell our residents, you are the specialist, all right? People who come to you very frequently are people who were mistreated or badly treated or wrongly treated or whatever by primary care physicians. And primary care physicians prescribe mostly, they may prescribe benzos, but they mostly prescribe second generation antipsychotic and SSRIs. And I said, how do you want to be the specialist whom people with mental illness are referred to if you don't know more than the primary care guy? So you need to learn to prescribe them. As far as the lack of new data, actually, I just reviewed a manuscript on, again, some systematic review on the use of benzodiazepines in GAD, and it showed the same stuff. The problem is that we are in the hands of pharmaceutical industry. Nobody in the pharmaceutical industry who has an antidepressant which works for anxiety is going to compare it to benzodiazepine voluntarily, because they have no interest in that. Because what if? This is like nobody is going to check whether the urban legend about bupropion being less inducive of mania, whatever is true. Because if there is a study which shows it's not, then they use the urban legend. So there's not going to be much more recent literature because there's no interest to do that. And the NIMH, which should be the place where things like that could be addressed, invests only how many % of the budget for clinical stuff? Yes, 10%. The rest goes to basic science research. There are people like Fullatori and others who've been criticizing that for years. So there is no interest in that. The other thing is, I actually have more trust in the older studies because many of them were done in academic centers. And, I reread Carl Rickle's articles talking about that issue, how the academic centers were doing better. Drug companies are now doing huge studies, which look great because we have a great sample, but the quality is lower. If you have done drug studies like I did, I was participating in drug studies when I was young. It really is a complex thing, and when you get people in, no offense to people from Oklahoma, I use it as an example. In rural Oklahoma, you have a center for drug trial, which recruits tons of patients, and you cannot recruit them. Then there is some problems there. We observed that even in 1990s when we started to do we were doing trials in panic disorder. Once the medication was available, there were no volunteers for trials. So the trials done originally were not bad, they were done well. And we are not gonna get good research studies unless we get some funding from NIMH, because in the drug pharmaceutical industry is there for making money. We have to recognize that this is their purpose. We cannot blame that for what they do. We have to recognize what they do. They are there for money and paying dividends or whatever. So the moment they got the drug approved to the market, they're fine. They're not interested in anything else.
Any of the okay, Allison, hold on one second. Any of the addiction psychiatrists we have on the,
Yeah, I'll be interested.
any of you have any comments, questions, or any of the residents?
So this is Mike Mancino. I run the methadone program and the Suboxone program basically, and then addiction medicine trained.